help growing your family? The BioART Fertility Centre in Johannesburg is waiting to help you fulfill your dream. Our highly professional staff offer you world-class care and cost so low that you can afford to dream. State-of-the-art equipment and remarkable success rates. We have been treating all aspects of infertility for more than 26 years. Contact us now to make your family a reality. BioART Fertility, where life begins.
Our first speaker today is Dr. Tasnim Muhammad. Dr. Tasneem is a specialist in the field of obstetrics and gynecology. In May 2018, Dr. Mohamed joined BioART Fertility Centre as a gynecologist and also trained in the field of infertility under the supervision of Dr. Kasim and Dr. Dasu. In September 2022, Dr. Mohamed commenced her fellowship training in reproductive medicine and endocrinology at the Steve Biko Academic Hospital in Pretoria.
Good morning to everybody. Thank you for the opportunity to present here today. Thank you to the coordinators, Saskia, Thandi. We know there's a lot of work that goes on in the background in order to make this event successful. And yeah, Thandi, I want to correct you. It's the 4th fertility show, 3rd live one, yes, but the 4th one. Yes. And each year, your, is this better? Yeah. Okay, and each year your outfits get better and better. So congratulations. Okay, and another welcome to the audience for taking the time out to be here. And thank you for actually coming to these events, because without you guys, there is no event. Okay, so the topic that I've been asked to present is fertility testing and diagnosis. Now, it's a basic topic and probably a nice topic to actually start off this weekend's talks. And it is based at a very basic level because I want it to be targeted at the audience. You guys often come to fertility clinics, doctors talk big words, don't really grasp everything that we've said, and that's our fault too. So just an overview of what to expect when coming to fertility clinics, coming for fertility workup, what kind of tests we will be doing, and a little bit on diagnosis at the end. Okay, so as Thandi mentioned, infertility is tough. Okay, it is really tough. It is emotionally difficult. It is physically difficult, and it is costly as well. Okay, but it is also common. The incidence of infertility is reported at 10 to 15% of couples in the reproductive age group, and a bit more closer to home. In some studies here in sub-Saharan Africa, these numbers have been reported to even be as high as 30%. Now, what is infertility? What is the definition of infertility? What does it mean when we say we have a problem of infertility? So infertility, by definition, is the inability to conceive, of a couple to conceive, after 1 year of regular, unprotected intercourse. Now, in women who are older than the age of 35, this timeline actually changes to 6 months. And why do we change this timeline to 6 months if you're over the age of 35? So as you can see from this graph, okay, from the ages of 20 to 30, there is a decline in infertility. Okay, so this is the annual fertility rates per 100 women. Okay, from 30 to 35, there's again a further decline. It's a bit more steeper than this line. And then from 35 onwards, this line actually is quite steep decline. So every month counts. Okay, so after the age of 35, we don't want to wait for a whole year before we find out what is the problem and before we start treating. Okay, now this is the latest definition of infertility, and it's the WHO, which is the World Health Organization definition. And as you can see, it's diagnosed as a disease characterized by the failure to establish a clinical pregnancy after 12 months of regular, unprotected sexual intercourse. So what is a disease? A disease is something which generates disability as an impairment of function. And this might be physical, emotional, psychological impairment. And this is very important, and that's why I'm so glad that our medical aids have come on board, or some of them anyway, because if it's a disease, then it needs treatment, okay, and they need to then come on board to actually assist us with this. Okay, so other parts of the definition. It's also due to an impairment of a person's capability to reproduce either as an individual or with his or her partner. So if there's a known problem, okay, either with an individual or with the couple, they need to possibly come in for assessment earlier as well. So fertility interventions may be initiated in less than 1 year based on age, as we said earlier, okay, so the age of 35 and above, or above 35, and if there's any known medical, sexual, and reproductive history, or physical findings and diagnostic testing which has been done, which has shown that there is a known cause of infertility. So this is just the first take-home message, okay? So when should you be concerned? And when should you have your testing done? So you should be concerned if you are over the age of 35 and you've been trying for more than 6 months, if you are under the age of 35 and you've been trying for more than a year, and if you have a known fertility problem, regardless of how long you've been trying, then you need to actually present for testing, diagnosis, and further treatment. Now, who should do the testing? And who is doing the testing? And where should these tests be done or conducted? Now, some patients have actually had a lot of their testing of fertility done with their general practitioner. And this isn't necessarily incorrect, okay? And some GPs actually do quite a lot of the basic investigations already before referring on. Also, the gynecologist and the urologist. Problem with here, and again, not incorrect as well, but it often will be one-sided. The gynae will investigate the female, and the urologist, if you're going to urologist, will be assessing the male partner. If you have or meet the definition of infertility, it's often a good idea to actually visit a fertility clinic or be seen by a fertility specialist so that you can have a comprehensive assessment done. Okay, radiology. So sometimes the GP, gynae, urologist, fertility specialist might refer you on to a radiologist who might assist as well in the fertility testing in the form of tubal patency testing, ultrasounds, and things like that. Okay, now with fertility testing, again, I emphasize it is a couple. Okay, infertility is a couple's problem. It's not one partner or the other. It affects both. So the couple must be investigated. History, very important. We've got a few slides just on basic history so that you will all be asked the same questions when you go to your fertility doctor. And probably people who are not new to the journey already know everything that is going to be asked in the history when you come for the consultation. Okay, so history is important, and a lot of information can be elicited just from the history, just by taking a good detailed history from both the male and the female partner, and then a good physical examination. Okay. Now with history, lots of things will be asked. Okay, when we use the term primary and secondary, this just basically means, and it can be for males and females, primary means that you've never conceived before, okay? And secondary means you've had pregnancies before, so a female, or on the male side, they have children or a history of having impregnated someone before, and now they're struggling to conceive again. Okay, on the female side and on the male side, detailed medical history is important. As we know, lots of medical conditions can also impact on fertility, as well as surgical history is always important as well. Okay, so history of surgery to the abdomen, to the pelvis, and in males as well, to the groin, to the testes, very important in terms of history. Medications are important, so chronic medication, medication that we're using for certain medical conditions, medication that we're using for depression, anxiety, and sometimes medication that we don't even consider to be important maybe to mention, like herbal medication. Remember, these are all medications that actually, they have those drugs in it, and we don't always know what's in certain herbal compounds. Okay, and then your over-the-counter medication. So you will be asked about all these things when you present for your fertility testing. Social habits, here, that's smoking, alcohol use, other drug use, so your illicit drugs, important. And then a history of infections. STI stands for sexually transmitted infections, which can affect both male and female fertility. On the female side, menstrual history, probably one of the most important things that we elicit on our history taking is the menstrual history. What is the cycle like? Are you having periods? Are they regular? Okay, so you will be asked all those questions. When was your last menstrual period? Okay, and your obstetric history. So what was the previous deliveries? Were there any complications? Were there any problems there? And then on the male side, a history of any trauma to the testes. So whether it's sporting injuries, soccer, kicks, rugby injuries to the testes, the groin area, other trauma, torsions, so those kind of things will be all very important to elicit. Physical examination, just quickly, weight, BMI does play a role, okay, both male and female infertility, and that will need to be checked. Examination of the thyroid, which is this gland here in the neck, okay? If it is overactive or underactive, it can affect fertility. In the female, examination of the breast, abdomen, pelvis, and the genitalia. And again, in the male, examination of the groin and the genitalia. Now with female, and I will be talking a bit more on female than males today, and the reason for that is that there is a talk later this afternoon after lunch on male infertility, and I hope everyone will also be here to listen to that talk. It's going to be quite a good talk. It's by Dr. Moato. It's on male infertility and your options. So with females, investigations that might be done, including blood investigations, so hormonal analysis, blood analysis, definitely an ultrasound, okay, lots of information from the ultrasound, and in certain instances, tests to assess the fallopian tube, so tubal patencies to see if it is open or not. And depending on what is picked up from your history, examination, and your ultrasound, your doctor, fertility doctor, might suggest further testing in the form of surgery, minimally invasive surgery, your laparoscopy, and sometimes your hysteroscopy. Okay, not only for diagnosis, but also for treatment. Blood tests, which you will often be required to do, is blood tests for females, hormone profiles, AMH test. And AMH, those who again are not new to the fertility journey will know this term. Okay, so it stands for anti-Mullerian hormone, and it is a marker of your ovarian reserve. It's a very important test that we also do in part of the fertility workup sometimes. Okay, thyroid function, prolactin, in certain instances, okay, and sometimes blood tests for antiphospholipid and autoimmune screen if you have a history of recurrent pregnancy loss, or if you've got a history of recurrent implantation failure, your doctor might also request this test. Tests for infections, syphilis, hepatitis, HIV, rubella, that's usually basically standard testing that we do. Okay. Ultrasound, as I said, is probably one of the most important things that we as doctors do. Gives us a lot of information. And there's two ways that we can do an ultrasound. It's transvaginal, transabdominal. Mostly we will be doing this examination, the transvaginal one. The reason for that is we get better evaluation of the pelvis, we get a better image resolution. Is a bit invasive, okay, but it's also better for assessment in our obese patients and better for the retroverted uterus, which means the uterus that is pointing backwards towards the spine. Transabdominal ultrasound does have a role as well, and this is if we want a more overview, panoramic view of the pelvis. It is non-invasive. It's just done from the abdomen. Okay, we can assess with an abdominal ultrasound the abdomen as well as the pelvis, and it's very useful in patients where we cannot do a vaginal scan, maybe because they're unable to tolerate the vaginal probe. Ultrasound pictures, okay, you will all be watching the screen when we're doing the ultrasound, and you'll see these pictures, but you might not know what we're looking at. Okay, so we're looking to see the uterus, so the muscle part, the myometrium, the inside part of the uterus, the endometrium gives us a lot of information, the position of the uterus, so anteverted, retroverted, and we're looking at the cervix to see the different ways that the cervix is also. So this is an interesting one because the cervix points upwards and then the body of the uterus is pointing downwards. Okay, so those are things that we're looking at when we're looking at the uterus on scan. Scan also very important, tells us about where you are in your menstrual cycle and if it's appropriate for where you're saying you are in your menstrual cycle to what we're seeing. So in the early part of your cycle, you want a nice thin endometrium. As the egg is developing, okay, we get a lovely appearance, and your doctor will say you have a nice trilaminar appearance, and then that's what we mean. Okay, so we mean that it's got this nice three-line appearance. Okay, and that tells us that the egg is developing, it's reproducing estrogen, which is the endometrium is responding to. At ovulation, okay, you'll still have this nice trilaminar endometrium, and you'll also see changes in your cervical mucus over there. Okay, in the later part of your cycle, so after ovulation, the endometrium changes, and we also want to see that when we're doing a scan. Okay, to see if it is now, we've lost that trilaminar appearance, it's thicker, it's compacting, and it looks good and secretory for an embryo to be implanted. Ultrasound can also tell us about pathology. Okay, those pictures were a nice normal uterus, normal endometrial cavity. Okay, sometimes we'll see on scan something that looks like this. Okay, and we're not quite sure. You can see in this picture, it's the same one from this patient over here, where there's been some fluid now installed into the cavity, and we can appreciate that there's a mass here inside the endometrial cavity. So that's basically where the baby needs to grow. There's something that's there. Okay, and that's a polyp. Okay, you can see there's some blood flowing through it. Okay, so that's an endometrial polyp, and that often will need to be removed first. Okay, and then this is just a nice 3D picture of an ultrasound. It's a coronal view, and you can see that polyp as well in this picture here. Fibroids. Okay, so fibroids have an impact on fertility. I don't think there's a talk on fibroids this year, but they do have an impact on fertility, and they, especially if they are big, especially most importantly, where they are, the position of the fibroid. Okay, so fibroids that are very big, fibroids that are inside the cavity, the endometrial cavity, again, that's where the baby must grow. If they're there, it's going to affect your fertility. It's going to affect your ability to conceive, and it will need to be removed. Okay, just again, an ultrasound picture and a 3D picture, which is showing the fibroid. Okay, and then this picture is showing something interesting. It's showing a niche defect or a Caesar scar defect or an isthmocele. So when your doctor says any of those, they're meaning the same thing. Okay, so this is, as I said, a Caesar scar defect. Usually occurs after one has had a cesarean section. And we're not always sure what causes it, but it can also affect subsequent fertility and pregnancy. And sometimes it's a small defect, and sometimes it's a big defect, like you can appreciate here. Okay, and when it's a big defect and there's fluid draining from here into the cavity, okay, that can again affect fertility. And sometimes your doctor might even suggest treatment of this before. Sometimes on scan, we see pictures like this, okay, with these little white spots, which is calcifications. Okay, and you can see it here as well. I don't know if these pictures are projecting very well, are they? Yeah, okay, all right. And then that can tell your doctor that you might have some scarring inside your womb, okay? These are pictures of adenomyosis, so ultrasound findings of adenomyosis. There's a talk as well on adenomyosis. Adenomyosis and endometriosis, big cause of, contributing cause of fertility problems, infertility, and there's a nice talk on it later as well. Sometimes on scan, we'll see different shapes of the uterus. You can see here, this is, remember I said the endometrium, and it looks like there's a break in the endometrium here. Okay, and you can see these pictures all look pretty much the same, but if we do a nice 3D reconstruction of this, we can see possible pathology, a nice heart-shaped uterus, deeper, reflecting a septum, and a very deep septum as well, which can affect fertility. When we're doing our ultrasound, we'll also be looking at the adjacent structures, so on the sides of the uterus as well. We want to look at the ovaries, we want to look at the fallopian tubes. And your doctor might mention words like hydrosalpinx. Okay, so when we're saying that, we're seeing this on ultrasound or something that resembles this. So it's a cystic, fluid-filled area on the side of the uterus, which is showing basically the fallopian tube. Okay, normal fallopian tubes, we don't often see them on ultrasound. So when we're seeing them and when it looks like this, we are concerned. And you might need to have further treatment of this before. The ovaries, again, very important when we're doing your fertility testing, that we're looking at your ovaries. So we want to look at the ovaries, these little circles which are called antral follicles, and we want to have an idea of how many there are. So in this first picture over here, you can see there's a lot of these little circles. This is actually a polycystic ovaries, a lot of antral follicles. Okay, the second one, you can count, there's about 5 that I can see there. And then it does depend on your age, but depending on your age, this could be an appropriate antral follicle count when we're doing your scan. And in this picture over here, you can see there's just one little antral follicle. So if we, as doctors, are scanning and we're seeing this, we might say that we are concerned about your ovarian reserves, that the egg number looks like it might be low. We also look for cysts when we're doing your scan. And there's just different pictures of different cysts that we might see. Okay, this one here specifically is an endometriotic cyst. So we see this in patients who've got endometriosis, higher stages of endometriosis. Okay, so that's what we call a chocolate cyst as well, which your doctor might also use that term. Okay, then moving on to other forms of testing apart from the ultrasound. Okay, we might refer you for an HSG. We might do an HSG, which stands for a hysterosalpingogram. And those of you who've had a hysterosalpingogram will know it's not the nicest procedure to actually undergo, but it gives you a lot of information. It's not the only way that we can assess the tubes, but it is probably one of still the most common ways that we assess the fallopian tubes. Okay, oops, sorry. And in this picture over here, you can see, so it tells us not only about the tubes, it also tells us about the uterus. So they're injecting a dye and at the same time doing x-rays to see how it fills, if the uterus is normal, if there is normal filling and spilling of the fallopian tubes. And again, this picture here shows filling of the uterus, which is normal, filling of the tubes, but no spilling. So it's not coming out the dye, and it's making these little collections in the tube, which is again the hydrosalpinx that we don't like to see, that we're worried about. Sometimes there can be problems with the filling that we can pick up as well by doing an HSG, and that can tell us that maybe there's adhesions or blockages inside the uterus as well. And the HSG can also sometimes tell us about the shape of the uterus as well, as you can see in here, compared to what the uterus looks like here. And then endoscopy. So that's the surgery that I mentioned just now that you might have to undergo. And this is for investigation, diagnosis, and sometimes also for treatment, and often for treatment actually. Okay, so what is a laparoscope? Okay, laparoscope is a minimally invasive procedure. It involves a small camera that goes through the belly button, most commonly. We're using a gas medium to distend the cavity, so to distend the abdomen, so that we can visualize and we can see the uterus, the ovaries, the fallopian tubes. We can assess the tubes as well by injecting a dye. We can treat at the same time, removing fibroids, removing adhesions, removing hydrosalpinx as well. Okay, and then hysteroscopy, again, it's a small camera procedure that involves a camera going through the cervix, that's the mouth of the womb, to visualize and to look at the inside of the endometrial cavity, again, to assess it, to treat for any adhesions and if there's any fibroids that are inside the cavity. Sometimes, depending on the size, it can also be removed through this procedure. With the males, as I said, just one slide. Sorry, guys, you'll have to wait for the afternoon talk. But cornerstone investigation on the males is a semen analysis. Just a basic semen analysis. Okay, so they get off easy usually. Hey. Okay, so semen analysis and then blood tests. These are just standard again. So the syphilis test, hepatitis B, HIV, and maybe further testing depending on what we find on the semen analysis. And sometimes your doctor might suggest other tests as well, again, depending on what is found on the basic semen analysis, which is further tests for DNA maturity, DNA fragmentation. Once all the testing is now done, the next part is to make the diagnosis. Now, causes of infertility. What is the problem? That's why we do the testing, right? Because we want to know what is the cause. Okay, so it can be male factors. It can be female factors. And often it can be a combined factor, so a male and a female factor. Female factors, so all those tests that were done were to determine whether there's any problems in the uterus, uterine pathology, your fibroids, your polyps, problems with ovulation, okay, problems with your ovarian reserve, problems with your fallopian tube, problems with the pelvis and the structure, adhesions, and other problems like endocrine problems, metabolic problems, autoimmune problems. Male side, usually problems related to the sperm parameters, which can be problems with the count, the number, problems with the motility, the way they're swimming, and problems with the morphology, the appearance. And probably the worst of all is the absence of sperm. But then that's again, further testing will be required, whether there is sperm, but it's just not coming out, or whether there's no sperm being produced. Okay, and then the treatments again will be different depending on what these tests show. And other things like varicocele, hydrocele, and obviously other things. Okay, that brings me to the end of my talk. Okay, and I thank you to everybody for your attention, and I hope everyone enjoys the rest of the show, and I think it will be a great show.